Okay, let's start now. So it's the last minute presentation. So I will be discussing about a patient who had severe TVD and who had severe aortic stenosis. Thank you for this opportunity, Dr. Sarath Chandra sir, and hi, Dr. Ranjan. Hi, everyone. So he's a 87-year-old male, prior history of hospitalization for hospital. He has got significant risk factors in the form of hypertension, hyperlipidemia. He's prior ex-smoker. He had a CVA with mild residual hemiparesis. He had history of paroxysmal atrial fibrillation. He's not on anticoagulation because of history of significant GI bleed before. His STS score was 5.56. He had an sorry about that. Yeah. He presents with exertional shortness of breath, fatigue, leg edema. Echocardiogram showed an severe stenosis with a gradient of 60-30, 60 peak and 38 of mean, as LV function of 40% with a low flow, low gradient aortic stenosis. Stroke volume index was 30. His EKG showed a normal PR on narrative virus. The heart team found him as a high risk candidate for surgical aortic replacement. He's planned for a revascularization followed by TAVR. The cath, I forgot to mention that cath at an outside hospital showed severe TVD with the left main disease. This is the CAT scan of the particular patient, a three-dimensional workup of the particular patient. For an aortic valve annulus. Can you guys see it or not? Hello?
Yes,
Yeah,
sir, we
we are
can see.
seeing
Yes,
you.
we see. We see. Go,
Okay.
please.
Yeah, the annulus area of 494. You can see the annulus area of 494.7 millimeter square, perimeter of 79.4. The aortic annulus minimal diameter of 23.4 with a max of 27 and an average mean diameter of aortic annulus of 25.2. If you can see it here, the left main is arising on the relative on the lower side, 7.2 millimeter, and the right is okay, 13.8 millimeter. The sinuses were quite good in size, broad in size. So there is a mild calcium at 8-9 o'clock position in the STJ level. This is the femoral anatomy of the particular patient. He's got significant circumferential calcium in the common iliac near the aortoiliac junction, but the lumen appears reasonably okay. At the site of at the puncture site in femoral anatomy, at the femoral head site, there is no significant calcium. The tortuosity also not great. Kind of acceptable femoral anatomy. This is a stretched view of the femoral anatomy. The coronary angiography. Since we know the anatomy of the particular patient from outside cath, we didn't take multiple shots. We just confirmed the left coronary artery anatomy. We got a very tight distal left main disease, 111 lesion with a 70-80% lesion in the prox RC and a tight 80-90% is in the AV continuation vessel of the right side. So we initially did a BAV with a 20 Zima-2 balloon, followed by we proceeded with the placing an Impella CP system through the right percutaneous, right femoral artery percutaneously after putting 2 pre-closes. This is the guide shot for the coronary anatomy of the left coronary system. You can clearly see a long critical disc in the distal left main 111 lesion that is in the LAD extension to the proximal segment 2. So this is the RAO caudal shot. Again showing the critical left main, distal left main pathology anatomy. The flow was much slow. Kind of 2 on the circumflex system. So we proceeded with burying the circumflex system first with the 1.5 burr, followed by 1.75 burr for the circumflex system, and then proceeded with burying the left main LAD with the same 1.75 burr. This is the post This is the post burr shot. Good. Then we serially, I didn't show all the pictures for time shake. We serially dilated the distal left main LAD and circumflex system with the angiosculpting with the cutting balloon Wolverine 3.5 into 8 on both sides. and followed by long, kind of non-compliant balloon dilatation on the distal left main and LED circumflex with the long non-compliant balloons. Then we use mini-cut strategy to stent the left main LED and circumflex, with the circumflex being the side branch, 30818 in the circumflex and 3.538 in the left main LED system. This is the end result of the procedure. In the cranial view, and this is the end result of the procedure in the caudal view. And impella was taken at the on the particular day in the cath lab itself, and patient went home next day after having a non-significant, kind of insignificant post-operative recovery. 2 months later, he came back again for a PCI to RCA. So this is the check shot of the left side. This is the AL 0.75 guide shot of the right side. Again, showing significant calcium in the prox RCA segment with the tight RPL AV continuation disease. Initially, again, rotablate the proximal lesion with the 1.5 burr, and then rotablated the distal lesion all the way down to the AV continuation with the same burr, 1.5 burr. And the burr in the proximal segment alone was upgraded to 1.75. And then later on, kind of 2.75 into 8 Wolverine was used to cut the distal, and a 3.58 was used to cut the proximal RCA segment, and stent followed by placement of stents in the AV continuation and in the proximal RCA. This is the end result of the procedure. Again, at this time we didn't use any support. Patient's LV kind of remained the same. It improved 5%. LVO EO ejection fraction was 45% during this point of time intervention. And later on, the game of TAVR, on 1 month later, he came again for a TAVR. This is the groin shot this time. This is the arch angiography site. It's a kind of type 2 aortic arch. This is the annular shot. Showing the coplanar position. Sentinel was deployed from right radial, and this is the we used a S3 Ultra 26 millimeter valve with the left main protection because the height was low and the stent was there. The leaflet was quite. If you look at the 3-month sheet report, what I showed before, the leaflet was quite long. The leaflet may go, and the calcium in the leaflet may go and obstruct the left main in spite of having a stent there. So we thought of protecting it with just with a wire without having a stent. So this is the left main protection shot, and S3 Ultra was deployed. This is the post-deployment shot that shows that flow in the left main is preserved without any significant white line sign that's seen on the left main ostium. We always take another cranial shot to ensure that we are good. The most important reason, in spite of having a low left main origin, the flow is preserved because of a broad sinus. So leaflet can easily be accommodated inside the broad sinus. This is the pigtail shot. This is the final DSA shot of the left groin. He was discharged next day. He went home this time again happily. Thank you. This is the last presentation. So any hiccups, kindly forgive me. Stay safe. Thank you.
Thank you very much. Thank you very much for this very, very beautiful demonstration of a very high-risk patient, high-risk angioplasty and TAVI. So I think we can discuss later at the end.